So in order to deal with this, to break it down, like I'm going to talk about the life cycle for central venous catheter with the goal of standardizing practice at the highest level at each phase of the life cycle. And the life cycle goes like this. Phase 1, the assessment phase. Phase 2, pre-insertion, what you know is the insertion bundle. The third phase is the actual insertion of the device, followed by nursing care and maintenance and the removal. Another way to look at this is the chain of CLABSI prevention, and the chain is only as strong as its links. In other words, we have to do standardized practice at each level of this, each time. Not once in a while, like not when Jack's on call. Each time we have to do this. All right, talking about assessment, briefly, this is vital. So basically, when you're in the CLABSI committee, question number 1 is, was there a need for the line? You know what I mean? Like, clearly, this is the dominant question. Was there a need for the line, right? So basically, there are good reasons to put in one of these catheters, and there are bad reasons. Good reasons include hemodynamic monitoring, total parenteral nutrition, right? You can't do hemodialysis without a central venous catheter. Peripherally incompatible meds. This slide was furnished to me by the great Joe Bunch, RN from Chicago, and they gave a high concentration of bicarb and Levofed through that peripheral IV in the antecubital fossa. The patient didn't get CLABSI. He lost his arm, right? But he didn't get dinged for a CLABSI. And you see these blisters? What it means is all the tissue between the vein and the skin is dead. All the tissue there is dead, and they took off his arm because it was dead, right? And another reason to put in these is multiple access and critical illness. This was furnished to me by Matt Gibson. This patient has 3 non-standard IV cannulas, and they were asking for a 4th. Hey, give him a central line, right? But there are bad reasons to put in one of these catheters. And the worst reason is general access. Hey, Dr. Ladon, I couldn't get a peripheral IV. Can you come put in a central line? I did that for decades until we developed the nursing vascular access team, and then they would solve the problem with like ultrasound guidance. So basically, if you have one of these difficult IV access patients, and I know you have them in Richmond, right? You want to go to an ultrasound guided peripheral IV or a midline before you get to a central device. And this will cover 97, 98% of your patients. This simple scheme. So basically the message is, have a good reason to put in one of these lines.